Hello and welcome to the channel Nursing Rhythm. Today we are going to learn about the congenital abnormality, that is esophageal atresia and tracheoesophageal fistula. So we will see first the normal anatomy. So trachea and esophagus both are independent from each other, and trachea is known as the windpipe and esophagus is known as the footpipe. And esophagus is connected with the stomach, and the primary function of esophagus is to transport the food from the mouth to the stomach. The trachea is a part of respiratory system and the esophagus is the part of the digestive system. So in this condition, there is an abnormal connection between the trachea and esophagus with a fistula. So you can see in here there will be an abnormal connection between the trachea and esophagus, and if we will talk about the esophageal atresia, then there will be a discontinuation in the pathway of esophagus. So it will what it will do, it will make two segments. The esophagus is divided into two segments, the upper and the lower segment. Means there will be no patent pathway in between these two segments. So one by one we will see. So here you can see in this picture there is fistula formation in between the trachea and the esophagus of the infant. Now we will see the definition. The esophageal atresia is a failure of esophagus to form a continuous passage from the pharynx to the stomach during the embryonic development. So at the time of embryonic development, there is a failure of a continuous passage, a patent passage between the pharynx to the stomach, and there will be formation of two pouches, the proximal and the distal end. And in the tracheoesophageal fistula TEF, there is a fistula formation. There is abnormal fistula formation in between the trachea and esophagus. So now we will see the incidence. So the TEF occurs in 1 out of 3,500 babies, and the male babies are more prone to get as compared to the female. Then the TEF are more common in prematurity, and 34% of cases are of the low birth weight babies. Means the premature and low birth weight babies are more prone to get this TEF. And if we are seeing then the cases of polyhydramnios, the mother who are having the history of polyhydramnios, then the baby is having these kind of conditions. So what is polyhydramnios? Polyhydramnios is the abnormal increase in amniotic fluid. And now we will see the etiology. So the exact cause is not known in most of the cases, but some of the factors are always influencing such condition. So here the first factor is hereditable, means the condition can be passed from one generation to the next generation. Then genetic factor, there can be a faulty gene which is responsible for causing such kind of condition in babies. Then the third is teratogenic. So teratogenic means the toxic agent. If mother has ingested any kind of toxic agents from any kind of route, like either from smoking, alcohol by taking alcohol, or by ingested any kind of drugs, then that can cause the abnormality in the baby. Then the intrauterine environment. So we all know that intrauterine environment is very much responsible for causing such kind of disease. So intrauterine environment may be have for example, if the mother has not taken nutritious diet during pregnancy, it can affect the baby and can cause such kind of condition. So these are the factors which influence such kind of incidents, but the exact cause is not known in these cases. Now we will see the pathophysiology. So at 4 weeks of gestation in the embryonic life, a laryngotracheal groove is formed, and it is responsible for dividing the foregut into two longitudinal tube, the respiratory tract and the digestive tract. With this two longitudinal tube, it develops into the respiratory tract and the digestive tract. But here what will happen, there is a deviation, or there is incomplete septum formation or incomplete fusion of tracheal fold. So in this condition, there is abnormal incomplete septum formation, or there is an incomplete fusion of the tracheal fold. So in this condition, what will happen, there will be malformation of trachea and esophagus. So in this this is the simple pathophysiology what we can see in this condition. Now we will see the classification of EA and TEF. So there are 5 classification: type 1, type 2, type 3, type 4 and the type 5, that is H type. So the type first is esophageal atresia without fistula. So the name itself suggests that esophageal atresia will be present, but there will be no presence of fistula in between esophagus and the trachea. So it occurs in 8% of all cases, and it is the second most common type of condition, TEF or EA. So this is 8% of cases can be seen of type first, and it is the second most common type. And in this condition, you can see in this picture, there is atresia. So the atresia, due to atresia, there is no connection between the esophagus and the trachea, and it has divided into 2 parts, as I have discussed already, that it has divided into 2 parts, the proximal end and the distal end. The upper end is known as proximal and the lower is distal. So the proximal and distal segment of the esophagus are blind here. There is blind pouch present, but there is no fistula present. You can see in this picture, there is no connection, there is no abnormal connection between the segment of the esophagus and the trachea. So this is the first type of classification. Now we will move towards the second type of classification, that is type 2, esophageal atresia with TEF upper. So there is presence of esophageal atresia, and now there is presence of tracheoesophageal fistula with the upper segment. There is fistula formation between the upper segment of the esophagus and the trachea. In this condition, it is rarely found, and it is less than 1% of all the cases. Now you can see in this picture, there is fistula formation from the upper segment of the esophagus, but the lower segment of the esophagus is blind. So the upper segment of the esophagus open into trachea by a fistula, and the distal or the lower segment is blind, and there is also discontinuation. You can see, so atresia is also present, and tracheoesophageal fistula is also present, but at the upper segment. So this is the second type of classification. Now we will see the third type. The type third is EA with TEF lower. So this is very easy. There in the second type, we have seen that there is TEF present at the upper segment, but now we are seeing that the TEF present at the lower segment. Here you can see in this picture, there is atresia present, and there is fistula formation in between the lower segment of the esophagus with the trachea. So in this condition, the upper segment of the esophagus has blind end. There is blind pouch, and the lower segment of the esophagus is connected with the trachea by the help of the fistula. So it is the most common type, can be seen in most of the cases, and occurs in 80 to 90% of all cases. So this is the most common type. This can be come into your competitive exam also. The most common type of esophageal atresia and tracheoesophageal fistula, that is type third. So now we will see the type 4, that is esophageal atresia with TEF both upper and lower segment. So it is also rare, and it occurs less than 1% of cases. Here there is esophageal atresia with fistula between both the upper and lower segment. Means there is the fistula formation and the abnormal connection between both the upper and lower segment of the trachea and the esophagus. So we will see in this picture, you can see there is atresia present, and there is fistula formation with both the upper and lower segment abnormality present in abnormal connection present in both the upper and lower segment. So this is also known as atresia with double fistula. Now we will see the type 5, that is H type of TEF. It is found in about 4% of all cases, and it is not usually diagnosed at birth. So here there is no esophageal atresia is present. So there will be no esophageal atresia, but both upper and lower segment of esophagus open into the trachea by a fistula. You can see in this picture there is alphabet H, you can see in this picture, and there is fistula formation from both upper and lower segment of esophagus, and that is open into the trachea with the help of the fistula, but there is no esophageal atresia can be seen. Okay, so if we'll talk about the diagnostic evaluation, so in antenatal diagnosis, USG can be done, the ultrasonography. Then postnatal diagnostic procedure include the USG, plain X-ray, abdomen, chest X-ray, bronchoscopy can be done, the visualization of bronchioles, and in these cases of TEF and EA, there can be cardiac anomaly associated with such cases. So ECG and echocardiogram can be done to detect such associated cardiac anomalies in these two cases, TEF and EA. Now we will see the management. So management, if we will talk about the immediate management, then after the diagnosis of the infant should be managed in a propped up position at 30-degree angle to prevent the reflux of gastric secretion from the mouth and to prevent choking. So this is important to make the infant in a position of the propped up position at the angle 30-degree angle, and we should not give any kind of feeding to the infant after diagnosis. Nothing per mouth should be ordered here. NPO, the condition of NPO should be ordered by the physician. Then airway clearance should be done, as we have seen that there is lots of secretion in this case. So airway clearance is done with the help of suctioning, and oxygen therapy should be given to prevent cyanosis, as well as the baby is having struggle to take breath. To prevent this condition, we will give the oxygen therapy to the baby. Then the nasogastric tube aspiration can be done, as we have seen that there is lot of secretion. Then the blind pouch should be washed with normal saline, as to prevent blocking of the tube with thick mucus, as thick mucus can be accumulated at that place. So we will do the washing it with the normal saline to prevent blocking. Now we will see there is gastrostomy can be done, like there is opening can be done at the part of the stomach, so that feeding device can be inserted and we can give feeding to the baby to prevent aspiration. Then supportive care therapy can be given. Supportive care can be given with the help of nutrition requirement can be maintained. Then warmth should be maintained with the help of radiant warmer. Prevent infection can be prevented with the help of antibiotic therapy. Then respiratory support can be given with the help of oxygen therapy. Continuous monitoring of the baby should be done. The chest physiotherapy and postural drainage should be done to prevent the accumulation of secretion, and to treatment of any kind of complication can be done in the part of supportive care. Now we will see the surgical management. If distance between the upper and lower segment, means the proximal and distal segment of the esophagus, is less than 2.5 centimeter, then primary repair is done by division and ligation of the fistula, means closing of the fistula, and end-to-end anastomosis is done of the segment. So the anastomosis is done, a surgical connection is done in the case of TEF. Now the staging surgery can be done in TEF is ligated. Then gastrostomy is done to reduce the risk of reflux and to provide the feeding to the infant. Then in the second stage, both proximal and distal ends are anastomosed if the segment of colon can be done in colon can be taken, the segment of colon can be taken in reconstruction surgery, and this reconstruction surgery can be required if the gap between the proximal and distal end is more than 2.5 centimeter. So there can be reconstruction surgery can be done, and it is done at the age of 18 to 24 months. Then after this, gastrostomy and esophagotomy can be esophagostomy repair is done. So this is all about the topic TEF and esophageal atresia. Hope it will help in clearing your concept regarding this condition, and it is very important topic for your exam purpose, either it is for M.sc nursing second year exams or the B.Sc nursing third year's exam, and it is also a very important topic in the part of competitive exam. So hope this will help you in all the field, and please like, share and subscribe to the channel. Thank you for listening to my topic. So this is all about the topic esophageal atresia and tracheoesophageal fistula. Hope that it will help in your clearing your doubt, and it is very important topic, either it is your university exam or any competitive exam. So like, share and subscribe to the channel. Thank you.